Symptomatic treatments of Alzheimer's disease are really important. They're the only thing we have. We have no disease-modifying therapies. There's a great emphasis in the drug pipeline on the development of these disease-modifying treatments, and we're looking forward to having those. No doubt they're important, but they're not available. And as a matter of fact, they're several years away. So the important thing is, let's use the drugs that we have now. They are only modestly effective, but they are consistently superior to placebo in every double-blind, placebo-controlled trial. So the drugs that are available would be donepezil as an oral formulation, galantamine as an oral formulation, rivastigmine as a transdermal patch, and memantine as an oral formulation. So my strategy when I'm dealing with a patient who comes in with Alzheimer's disease, mild to moderate severity, I inquire about whether they would prefer a pill or a patch. I go with their preference. I start at the lowest dose. I titrate it up. Patients then progress, which they do, of course. This is a progressive disease. It doesn't mean the treatment is failing. It just means that the disease is progressing in spite of the therapy. So when that happens, I add memantine, and that takes me through several years of management, and I'm confident, based on the double-blind clinical trial data, that those medications are helpful compared to no treatment. There are patients that I think should not be on cholinesterase inhibitors. For example, bradycardia can be exacerbated by a cholinesterase inhibitor. So take a pulse. This is a great physician thing to do. Take a pulse, and if it's below 50, don't use a cholinesterase inhibitor in that patient. And then there are a fair number of patients who develop gastrointestinal side effects, particularly on donepezil, but also on the others as well. So a good gastrointestinal history is very important. It's not just about diarrhea, which is kind of what's discussed in the literature. For me, it's really about how many stools per day are patients having. So I ask, and at least 10 or 15% of patients have disturbing levels of gastrointestinal difficulties. And usually I try another cholinesterase inhibitor. For example, if that's happened on donepezil, then I would migrate them to the rivastigmine patch. Other things to be alert for would be nighttime disturbances, nighttime sleep and dreaming disturbances, which can be helped by providing the medication in the morning rather than the evening. And then some patients will get muscle cramps. And again, if they're severe, the drug must be discontinued.